Hi, all. Welcome. My name is Stephanie Boyer. I'm here from Override Health. I am very delighted and excited to speak with two prominent physicians in the pain field today. We have Dr. LaShort and Dr. Jimenez, and I would love for you to go ahead and introduce yourself. Welcome.
Hi, everyone. I'm Dr. Javier Jimenez. I am the Director of Consultation Psychiatry and Chronic Pain at Long Island Jewish Medical Center, which is the academic hub for Northwell Health. It's a large health system in and around New York City, comprised of 28 hospitals and many clinics. My current role is clinical and non-clinical administrative. I see patients with mental health needs, but also I'm pain medicine boarded and see chronic pain patients in my clinic. I'm also addiction medicine boarded, so I do see some of individuals who unfortunately are afflicted with chronic pain and associated concerns that are mental health concerns and addiction. It's a pleasure to be here today.
Thank you for joining us.
And I'm Christina LaShort. I'm a pain physician, anesthesiology by background, and I am the medical director and VP of clinical delivery here at Override Health. So here I also have sort of two hats I wear, just like you, Dr. Jimenez, where I am seeing patients. I have a clinic as well as do some of the operations work and oversee the teams that are delivering the interdisciplinary care that we do here. Great to be.
Yes, welcome. Welcome. Well, I why don't we just jump right into it? I have so many questions for you all, but I always like to start with understanding your journey a little bit, right? I feel like folks that end up in pain medicine are a special kind of person, and so I'm curious, what first drew you into pain medicine, and how has your perspective evolved as you've worked across different disciplines?
I went into medicine thinking that maybe I'd become a surgeon, maybe an oncologist, something of the sort. But all physicians need to experience a variety of disciplines. And the one that really resonated for me and really moved me was psychiatry. And so I actually trained first in psychiatry at the University of Pittsburgh Medical Center, had stellar training in psychiatry, but along the way, I always wanted to have some impact in the medical space. And so I specialized further in what's called medical psychiatry or consultation liaison psychiatry. And that's when I went to Mass General Hospital, part of the Harvard system, and did a fellowship there in that, specifically, again, mental health issues in the medical space. And I've not looked back. I've only worked in the medical space. It's been now 15 years of working with mental health concerns in the medical space. That first experience at Mass General actually exposed me to acute pain patients. I worked on a burn unit and a trauma unit as a psychiatrist. And of course, there were other mental health concerns to think about, trauma, anxiety, but we were actually assisting other doctors in alleviating acute pain surrounding skin grafts and other interventions that these individuals would face. Really terrible situations, but I learned a lot about pain management and how that could really alleviate, alongside mental health interventions, the suffering that some patients faced. And I never really forgot that lesson. After that, I trained and worked in a variety of different spaces that were medical, some more related to pain, some less. I went to the Cleveland Clinic and worked there for about 8 years. And once again, inserted myself in a number of medical spaces: transplant medicine, orthopedics, rheumatology, epilepsy. But the one that really took more of my attention and time and focus was chronic pain. It was a program there that's a multidisciplinary program with physicians, psychologists, physical therapists, occupational therapists, nurses, all working together to help severe chronic pain patients. And I actually became the director of that and worked with the team. And we had it takes a village approach, if you will, for these end stage individuals with chronic pain. And so it's sort of an accidental trajectory for me to get to this point. Within that space, I became pain medicine boarded and addiction medicine boarded, and felt very strongly that this is something that I should try to assist with and help with. So that was my journey.
Wow. Wow. Thanks for sharing
Yeah,
that.
sure.
Amazing. Well, my journey may be a little bit more direct, I suppose, than yours, Javier. So I came to pain medicine through a traumatic accident that happened when I was in medical school. And essentially, what happened was my house that I lived in with my younger sister burnt down. And in that accident, my sister had to jump out of the second story window. She suffered burst lumbar spine fracture, a something called a Lisfranc fracture of the foot, compound um, fracture of the foot, and so she had to go through numerous surgeries, 9 in total.
Wow.
Had injections, stem cell treatments, medications, and I watched all of this as I was a medical student and deciding, what I was going to do with my life. And in the end, all of the treatment she got, the interventions and medications weren't doing it, right? They weren't solving the problem. And what finally worked for her over the years was staying active, getting out into nature was something that was really healing for her, building a really healthy lifestyle. And she got into Pilates and all of that sort of, helped her deal with the pain of the accident. And now she's thriving, and it's been so many years and it could have gone really wrong in a really sad way. But so yeah, that shaped a lot of, my experience. Anesthesiology was a way to get to pain medicine. And so I did my training down in Miami in anesthesia and then followed up at MD Anderson for my fellowship. And it's been incredibly rewarding. What I've noticed throughout my experience is that, I was an interventional proceduralist, and a lot of that there's a time and a place for, but what most of my patients needed more of wasn't more procedures. They needed more time, guidance, empowerment. They needed a team-based approach. And so, hence why I ended up joining Override Health to help build that.
Mm, thank you. Yeah, I'm familiar with how both of you speak about, biopsychosocial pain care and this team approach, right? This truly interdisciplinary approach to pain care. But I was wondering if you could define, for the folks that will watch this, how do you define successful pain care beyond, just reducing pain scores, for example? Feel free to jump into.
Yeah, I'll just jump in if that's okay. Thanks so much, by the way, for sharing that very personal experience with pain and how it affected your family. And I'm just grateful for the silver lining here that now you're helping others as a result of this terrible
Yeah.
experience. But to answer your question, Stephanie, when I think of chronic pain in particular, acute pain might be a different ball of wax, if you will, but a particularly chronic, lasting, debilitating pain, I do think very often much more about pain on a 0 to 10 scale. I think that's critical to think about the effects of pain, the impact on quality of life, on functioning, on socialization. To use your word that I use very often, it's not just biological, but psychosocial ramifications of chronic pain. Chronic pain is, in a way, a complex syndrome. It's not just a pain signal that just keeps hitting the individual. It's also the effects of that uh, constant bombardment of pain. And you see a snowball effect, right? A vicious accumulation of different psychosocial, elements to chronic pain. So when I think of, chronic pain and alleviating it and see a new patient or evaluate someone, of course I ask about pain and location and alleviating factors and aggravating factors and all of that and do an exam. But I really also am thinking simultaneously about things like pain disability, pain avoidance patterns, pain thinking patterns like catastrophizing and things of that sort, not to get too jargony, but all of that has to be done at once, simultaneously, in parallel, if you will.
Absolutely. We talk a lot about all, fear avoidance, all the cycles of pain here. Um, I'm curious how you feel that you can, cover that in one appointment, right? How does a physician in your position address that, realistically, given that that chronic pain, to your words, I've heard you say this before, that chronic pain isn't pain that has just lasted longer. It's a completely different beast and requires a completely different approach. Um, is there any way that you can address that in a health setting like that?
Well, the short answer is no, not in the first visit. And I think it's actually very important to set the stage in the first visit that there is complexity here, right? Patients will come in and say, Doc, treat or fix my pain, right? Fix it, fix it, fix it, make it go away, which I think is perfectly understandable, perfectly natural for somebody who's living with unrelenting pain. But to do that or to alleviate pain and its ramifications, it's going to take some time. There's no shortcuts in this, in my experience. So actually, one of the very first things, I love this question you're posing. One of the very first things I do is to say, we're going to need time for this. And I sort of expand the goals beyond analgesia or pain relief so that it's about pain relief, but it's about other goals, functional restoration, if you will, achieving, quality of life, expanding your level of activity, expanding your world, which very often in the world of chronic pain, people's worlds sort of shrink over time because of reduced activity and socialization. So that's the answer I would give, is that no, I don't promise anyone that this is going to be fixed quickly. In fact, it's the opposite. It's going to take time. Let's devise a care plan that may take many visits and many providers that are working together to really treat you completely, right? Sort of whole care of the, not just, by the way, patient, the person that we are seeing, right? And they're different, not just patient, person. And so that would be my response to that. I'm the very first to not promise a quick fix.
I'd love to hear from you, Christina, what your thoughts are, in this conversation around successful pain care and even, to the expectations point.
No, I mean, ditto. All yeah, you've put it very well, Dr. Jimenez. But so one on the successful pain care. So completely agree. You have to focus on the function and the functional goals. For me, it's when does pain no longer control your life, but when do you have control of it, right? Patients might still have pain, but it doesn't stop them, and that's successful pain care to me. And so we're looking at, what are their functional goals. We're looking at improved just function at sleep, having fewer flares, less going to the urgent care center. All of those things are sort of the successful care to me. And 100% agree with the expectations and letting patients know that this is not a quick fix. This isn't going to be, a band-aid. We're working to treat that central nervous system that has been changed due to your pain. And so I like to remind patients, think of how long it's taken you or how long you have been in this chronic pain and your nervous system has learned it. And so it's not going to reverse overnight. It's not going to just turn off. It's going to take a lot of time and a lot of chipping away, but over time, things will get better.
Absolutely. Yep. I think we're preaching to the choir here. We're deeply aligned in this. But shifting slightly, I'm curious. There are some barriers, of course, to delivering this kind of care, this whole person care. With timing and so many barriers. But I'm curious to hear from you. What do you both feel that what are some of the biggest barriers that you experience by delivering this kind of care, integrative pain care, and how can we address it?
I've said this before, and we have to change our system. Unfortunately, that it's incentivizing the quick fixes, the procedures and the prescriptions, less so the interdisciplinary care. But I've also said before that I am hopeful that we are shifting towards more of a value-based system in the future, and that there will be more of a focus on functional rehab programs that I think will make a resurgence as we see that the healthcare system and the costs that we are using just are not sustainable. And so I am hopeful that things will improve, but that's the biggest barrier, I'd say.
Yeah, I would agree with those barriers, and there are plenty others. I'll just highlight a couple of others that come to mind. I think one is in medical education. Maybe Dr. LaShort can remember this also. In medical school, we receive very little information or education on what chronic pain is. Some on pain and pain physiology, if you will, but to extrapolate the lessons from acute pain onto chronic pain is actually an error. We need to think of chronic pain differently and as a more complex syndrome, as I mentioned earlier. I agree completely with what you just said a moment ago about how time changes the central nervous system. That's not something that most doctors really are equipped with when they leave medical school. You learn that in practice, and that's really not the best way to disseminate education. And then related to that, the second thing, the second barrier that I think about is sort of the exceptionalism, if you will, the specialness that neurologic health sort of gets in society. People tend to really learn a lot about, for instance, heart disease, kidney disease. But when it comes to the nervous system, there's really this vague, abstracted sense of what it is, how it works. Does it really affect me? It's more invisible. That's, I think, a huge barrier, not just in the medical education space that I mentioned, but also in the community. Imagine somebody with no medical training now trying to grasp how their central nervous system has changed over time. So I think more public dissemination of information about this, coupled with upstream medical education of our providers, along with the other functional restoration paradigm changes that Dr. LaShort mentioned, might alleviate part of the issue.
Yeah, that's a good point. Because once you're in the pain field, it feels like there's a lot of conversation around the nervous system, right? But delivering that to a patient really isn't, might not land. But I'm curious what advice you might give to just this next generation of physicians as you're talking about, some of the barriers. Who would you how would we build more whole person models of care, in your opinion? Dr. LaShort, you can go first.
Well, I think, Javier, you kind of touched on it. It does need to go back to medical education. That's how we're going to build that next generation. It has to come through the system. And so I would love to see more training in pain neuroscience and behavior change. I think it would be amazing if we taught young physicians motivational interviewing, and how to speak with patients in that way. Um, and then maybe there should be more of a focus on function, functional goals, and not just pain scores. A lot of our measures of quality are related to like pain scores, but what about function? And I encourage anyone to also try working with a team and see how that turns out for your patients. And if you can find that type of care or that type of system where you're getting to work with in an interdisciplinary fashion, you'll see this amazing shift in patients and their outcomes.
Yeah, I agree with those comments. I think in addition to that, this is even harder to protocolize. I think it's important to cultivate in the next crop of physicians to be a desire for or a sensitivity for complete person care despite specialization. I think very often physicians will pursue, in very technical, specialized identities, and they're needed. They're absolutely needed. But in that process might lose to no fault of their own because of the, cognitive, bandwidth they may have and the pressures that they face. They may lose sight of sort of the patient, the person, if you will, that is being attended to in that very narrow technical sense. And so you have a number of specialists trying their best, but they're really only addressing one part. And in that effort, we might be tripping up on each other and not quite seeing the big picture. That's a little harder to get around. But I think mentorship programs, clinical experiences with complex patients that haven't responded to highly specialized interventions, I think these kinds of experiences in medical education might, spark that awareness so that when these students graduate as physicians and specialize, they still have that sensitivity and awareness. And if it's not them who's going to do the whole person care, at least they can refer appropriately and tactfully and humanely.
Yeah, exactly.
Yeah.
Yep, exactly. Well, I feel really deeply honored to be able to have had this conversation with you both today. And I hope that a physician listening might, be sparked to explore this further. So I really appreciate your time today. And thank you so much for joining us.
Thanks,
Thank
Stephanie.
you.